All right, guys. Today, our guest is Dr. Alfred C. Griffin III. Dr. Griffin is the co-founder and CEO of LightForce Orthodontics. He received his BS in biochemistry from the University of Virginia, completed his DMD and PhD in craniofacial biology and at the Medical University of South Carolina, and earned his Master's of Medical Research and Certificate in Orthodontics from the Harvard School of Dental Medicine. In addition to leading the team at LightForce, Dr. Griffin is a practicing orthodontist in the Boston area and teaches at Harvard Medical School of Dental Medicine. Dr. Griffin, welcome to the show.
Happy to be here. Thanks for having me, Rich.
Yeah, absolutely. So why don't you just tell us a little bit about yourself and your background? I saw you went to MUSC. That's right around the corner from us.
Yeah, I'm actually jealous of where you guys are right now. It's fantastic. We had snow up here 3 days ago. So I came directly from Charleston to Boston. So it was a bit of a climate shift as well as a culture shift. Yeah, so a little bit of everything. But I'm in Boston now. My wife's from Boston, so I'm from Boston. So is the company. But you guys have it great down there. Miss Charleston.
Oh, yeah. I kind of think of them as sister cities. Whenever I go there, you can feel the history in both cities. Like, they definitely have a lot of history together, there's no doubt.
I try to, my family, we always go down there. Like, that's our vacation spot. I was down there for 7 years. And actually, that's kind of how I ended up there. I wanted to be a little bit different than my dad. My dad's an orthodontist. My mom's a dentist. My everyone's a dentist in my family. So I was like, all right, I'm going to be a little bit different. I'm going to only apply to programs that I can do a DMD and a PhD in, and was looking at some options in Michigan and Charleston were kind of my two top choices. And if you're going to do something as god awful as a PhD, you kind of want to be somewhere that's going to be fun and nice climate. No, and so it was easy decision. But no, it's fantastic down there.
Cool. So how did LightForce get started? What's the story there?
Yeah, so LightForce has been, we've been working on that for about 6 years, actually since my first year of residency. It was pretty clear from growing up. I mean, I would get picked up from school and dropped off in my dad's office, and I would watch him. I would assist. I would watch him bend wire and things like that. And so, if you're an orthodontist, it's an obvious idea. Yeah, we want to, get a straight wire appliance and customize braces that. Lots of attempts at partial customization, getting a little bit there. Maybe we get the face customized. We still don't have the base yet. So it was an obvious idea. It was just really executing on the technology, making something work. And that meant putting the right engineers in the right place, partnering with the right companies. And that's what I've been so lucky to kind of fall into up here in Boston. Is it's really a hub for 3D engineering and 3D printing.
Oh, is it really? I could imagine it. I just didn't know that. Okay.
Well, you have companies like the 3D software companies, Autodesk, Parametric Technologies, SolidWorks, Onshape. They're all
up there.
Global headquarters is in Boston. And it makes sense because they're around MIT, Harvard, all the. It's one of those things that's hard to recruit for because you need to have two things. You need to be a good software engineer, and then you also need to have a strong background in 3D matrix math.
Okay.
Now, I'm a millennial, so I can say this, but most millennials that come out, of college with an engineering degree, they'll learn how to do software, and they'll want to go immediately put that into practice. Maybe they create an app, or maybe they do something else. But it's hard. Most of them don't take that extra step to learn the math side of it as well, which is very tough. And so traditionally, a lot of those 3D engineers have come from international countries. So a lot of from Russia, Ukraine, some from China.
Like places where people have high degree of math knowledge. And
there's like math is just at a higher. I'm not exactly sure what it is, but that's just what we're seeing. And so, but for whatever reason, all those people are in Boston now. And so if you want to take a modern approach towards orthodontic software, Boston's a great place to be for that.
Right. Yeah. All right. So you're surrounded by all these people. You had the human resources and the brain power.
Yes.
And it came together.
Yes. And so it was just a matter of putting those people together, bringing them into orthodontics, really, showing them what exists today. And that was the first step, I would say, is was getting a 3D printing technology that made sense, that we can make a clinically acceptable bracket, and fully customize it. And by that I mean customize, make the slot better, make the custom prescription, and make a base that fits the anatomy of the tooth exactly. So there's a consistent cement space between every bond to make it more consistent. Then we decided to build the software, and that gets back to the original point is, we had the opportunity to partner with some bigger companies, work within their software platforms, and taking a look around. It just made sense to start from scratch. Take a new modern approach to orthodontic treatment planning software, where it can be in the cloud, on a browser tab, web-based, and develop our own compression algorithms that make that possible.
Wow, so starting from scratch, that's a big mountain to climb when you make that decision, right?
It was pretty risky looking back, yes. Yeah, but I'm very happy we made that decision now, especially with the people we get to see and work with every day.
Yeah, just from a layman's point of view, I never think of things that are 3D printed besides in like aerospace being super strong, like strong enough to be a bracket. Can you tell us a little bit about that? Like, what is this material made of? How do we?
Yeah, every time I present and talk to orthodontists, I always forget to tell them what it's made of. Everyone leaves the presentation thinking we make plastic brackets.
Yeah, like I'm thinking of 3D printing at your house. Like I know that's not what the deal is, but that's just what I think of in 3D printing.
So no, it's a polycrystalline alumina bracket, which is ceramic. So that's the same material that we use for all of our ceramic brackets today. Most of them, not 90% of them.
Okay, great.
The difference is that our most of those that are made today are made via injection molding. So they'll take a mold and they'll fill it up with same polycrystalline alumina, cure it, and then it'll end up, they have to take it out of a slot, which makes the slot a little bit divergent, and then they cure it, and they end up somewhere around 96% density. All of our brackets actually end up at 99 to 98% density. So
they're actually stronger.
They're actually stronger, more dense, and that's important for two big reasons. One is obviously you don't want it to break, you don't want a tiling to fracture or something like that, but also you don't want it to stain. So that's obviously, drink red wine, you don't want to have red brackets.
Good point. Yeah. So the less dense, the more porous.
The more porous, exactly. And it's funny, they actually tried 3D printing brackets about 7 years ago in Spain with polycarbonate brackets. Challenge is that the slot would open up with creep due to the torquing, and then the other big issue is that when the patients drank red wine or ate something with spaghetti sauce, they'd have red brackets for the duration of treatment. That's not a good fit for anybody.
In Spain a lot, yeah.
Right. It's funny, actually, when we were getting going, that was one of our big concerns, and so our favorite test to do was the Chianti test. We would take a bottle of Chianti, dump them on some brackets, finish the rest, and 3 months later we rinse them off and make sure that they didn't stain and they looked like new brackets. So
if it can take 3 months of that abuse, then I'm sure.
Yeah. Maybe some heavy wine drinkers as patients. We never know. You got to account for these people. So
absolutely.
Yeah.
So where did the name LightForce come from? Is there any significance to it?
Yes. Good question. So this is our third name. No one's going to ever accuse me of being someone great at naming companies. We actually started off as Sarah Line, and we had to change that because we're obviously concerned about that last part, being too close to a big player. Then we were Signature Orthodontics for another 2.5 years, and very recently we changed our name to LightForce. And the reason we changed it, one, we could get a trademark for it, but more importantly, it really it speaks to the core of our technology that enables this process, is light manipulation.
Yeah.
And so I think when we first announced the name, I got accused a couple times of some of the Facebook groups saying, "Oh, LightForce, that how pretentious for them to think that they use lighter forces than we do to move teeth." It's not it's not as much about light force. It's light as in like photons of light.
Absolutely.
How we cure material.
I come from a physics background, so my mind went to that first, but I get what they're saying. Forcing, yeah.
And then there is some element of using lighter forces. For example, if we use today, if we want to engage extra torque in anterior teeth, we may take a wire and put a bend in the wire and then jam the wire in, and then we're engaging a torquing force from that day on, versus
Yeah.
with a fully straight wire appliance where you have a good fitting bracket and wire interface. You can use a night tie wire to let that torque express gradually from not day one, but once you get into a rectangular wire.
Yeah.
So the torque is expressed gradually. So you may be able to get to where you finish with lighter forces.
Gotcha.
But no, light manipulation is really why we came up with that name.
It's a cool name. I like
Yeah.
it. It's a ring
And,
to it.
and then we just changed the logo as well. So it used to have a little lightning bolt and in a bracket, and we changed it to what you see behind me. So those are little rays going out in an L, kind of like for LightForce.
Oh, that makes sense. I like it.
Yeah, but it also speaks to the fact that we started off as a bracket company, but then we realized we can do many other things that benefit orthodontists. One of which that is actually developing a little bit of a cult following is our bite turbos, our turbo trays.
Oh yeah.
Yeah, so we can actually indirect bond bite turbos on the lingual side of the upper central incisors, which normally you would sculpt. It takes 15 minutes doctor time to get it right. You pull out the occlusal paper, make sure they're even, all that. What we realize is that if you know exactly where the lower incisor or lower brackets are going to end up, you can open the bite just the exact right amount using the lateral ceph to determine the hinge axis, and then open the bite exactly 500 microns away from hitting the lower brackets.
Yeah.
And it's a form meets function type of thing, because we know the PDL space at its biggest is about 300 microns. So even if the patient bangs down really hard, they won't hit a lower incisor.
There's no limit to what you can make, really. If you figured out how to use this great material that's already accepted, then now you can start 3D printing different pieces.
So at a super high level, we just believe in mass customization in orthodontics. It just makes a lot of sense.
Yeah, so tell us, what are all the ways you would compare what you're doing to traditional braces? Just to kind of walk us through what differentiates you.
Well, first of all, you start with the manufacturing technology. Traditional braces are classically made via injection molding.
Yeah.
And our braces everything we send you is either 3D printed or mass customized some way. Today, everything is 3D printed. So if you start by looking at the slot, you can just make a more accurate slot by 3D printing versus injection molding. So with 3D printing, you manufacture with layers. So you get layer, and you get they call it staircasing. So if you're making like a round object, maybe you get some staircasing, a little roughness in certain areas.
Yeah.
But if the sensitive part of your device is a rectangle, which in the case of a bracket slot, it's a rectangle, you can make a perfect rectangle. So,
of course, that makes sense.
Yeah, right.
So the weakness doesn't make any sense. But.
Exactly. So we say taking customization completely off the table, you can just make a better bracket with 3D printing. So
do you think in general, traditional brackets will even be made via 3D printing instead of injection one day?
No, I think injection molding is going to go away as a technology to make braces. And we're at the very early stages. So everything's a journey. Everything takes a process. But certainly as the materials get better, the 3D printing process gets better, manufacturers learn how to use 3D printing, I think everything is going to be 3D printed. And there's a lot of I don't say inside baseball, but I've gotten a chance to talk to a lot of people in the 3D printing world, and some of the stuff that people are coming out with just makes so much sense and can easily be applied, not just to orthodontics, but other applications in the medical device space, in industry as well, automotive.
Yeah, custom medical devices for sure. I mean, there's so many procedures where it would be better if it was custom fit to the person's body.
Yeah, exactly. I mean, there's some cases that are more important than others. And by the way, the other big part of what we do is the slide. It's also the base. One other group has a custom base, but in a lingual system. So that's a very important thing that no one else has been able to do before. But to your point, why 3D printing in orthodontics? Well, I would argue that there's a higher value to customization in orthodontics than any other field of medicine.
Okay.
And the proof is that everyone thought that 3D printing, when it first came out, was going to have this huge splash in the orthopedic space. Like, we're going to be 3D printing casts, we're going to be 3D printing hip implants, 3D printing femur implants, all this stuff.
Yeah, that's what came to my mind when you're talking about it immediately. Yeah.
Yeah. But the reality is that the big winner for the 3D printing space was Invisalign. It was
That's true.
orthodontics.
Yeah.
That's Invisalign was really, even today, the best example of a scaled application of 3D printing.
Hmm.
Now the the liner itself is not 3D printed. It's the mold that is 3D printed. Then you vacuum form top of it today. But that is the biggest success story for the 3D printing industry.
I didn't know that. That's interesting.
And what we've realized in the orthopedic space over the last several decades is that, yeah, there's some value, but in most cases, you can take a stock femur implant, hip implant, and there's more flexibility. So there's the matrix scaffold will adjust to, if you're 3 millimeters
Really?
off or something like that, and it's going to be fine. There's no real changes in morbidity or case outcome.
Mm-hmm.
There's certain slivers of applications where that's not true, where there is value to customization, but those aren't today big enough markets for 3D printing to really make that same level of impact that Invisalign made.
Yeah, I mean, what a huge impact. Yeah.
Right. So we believe that, and it goes back to general dentistry, where with a crown you can be, you have several contact points, and it's you want to, if you're half a millimeter off, it's you're going to feel it in the occlusion. So same thing is true in orthodontics. If you're too high in the vertical, there's going to be an impact felt to that few millimeters.
Yeah.
Whereas in orthopedics, it won't. So there's just a higher value to customization in orthodontics.
Also, the value to the customer, they perceive it as much more valuable. Yeah.
They perceive it. It's to make a 3D printing application work, you need to check one of three boxes. One is there needs to be a high value to customization. Mm-hmm. Two is there needs to be a high part complexity, because you can make complex parts with 3D printing. Part complexity is free, like undercuts, making a perfectly rectangular slot, maybe undercuts in the base, things like that. Whereas with injection molding, you have to go in and laser etch afterwards to make the undercuts. There's an extra step. So value customization, part complexity, and then the third thing is people need to pay for it. So you can 3D print a coffee cup. I say this all the time, but why would you? It costs a couple bucks. Real value to customization. It's not really that complex. So you could, but doesn't make a whole lot of economic sense.
Yeah, that makes a lot of sense. All right, so from the doctor's point of view, what is it doing? What are these new custom brackets helping? How are they helping the doctor in their day-to-day?
Yeah, so you know what? A lot of various areas where they can help. We're learning from our customers more than anything, how they want to use it and how they're putting it to use. So I'll give you one example. Before, obviously, this coronavirus happened, one thing that a lot of our doctors were doing is they were using it to scale themselves and work at the top of their license. What I mean by that is they would, they determine the bracket prescription, they determine the bracket placement, and then a bonding appointment is really just installing hardware. There's no freedom for artistry. It's all the decisions have been made. And so, it depends state by state, but a lot of our doctors have delegated those bonding appointments to their staff.
Yeah.
Same thing if like a bracket comes off. We've seen far fewer debonds as a result of A, custom base, B, avoiding any occlusal contacts, but also rebonding brackets. If a patient chews on rocks, or I remember just before coronavirus, I had a patient chew on soft shell crabs that weren't that soft.
Oh,
They're still going to come off
yeah.
if they need to. They're not meant to be permanent. So having a staff, being able to delegate to a staff a rebond, where they can the staff can do the whole rebond themselves. Doctor needs to be there legally in most states, but
Of course.
there's only one place you can put the bracket. A, because the base is going to fit that anatomy perfectly, and B, the indirect bonding tray is going to put it right back where it needs to be. So scaling themselves.
Yeah.
The other area is wire bends. Doctors need to make fewer adjustments. The pan and repo visit usually turns into all right, let's schedule a debond visit. So it makes the doctor's headaches go away in large part. That's one of the biggest things that we didn't really anticipate, but we're seeing, and our customers are telling us, is that I'm using this not to finish treatment faster. I'm using this because it's going to reduce headaches for me in practice and help me scale myself.
We've talked about to a few guests. One was about virtual monitoring. Do you think combining those two could really reduce drastically the amount of appointments that they're physically at the office?
Yeah, so this is another way it's funny you just mentioned that. We're learning a lot from our customers today. And I would tell you that a lot of the tech savvy orthodontists are the guys who want to, and gals who want to try dental monitoring. There's LightForce, a lot of them do a lot of clear aligners.
Yeah.
And so I got a case from one of our big users the other day. It was a dental monitoring case. He was tracking with dental monitoring, and for whatever reason, the patient hasn't been able to get in since October. And so
Wow.
6 months in the same 014 night tie. And the patient just uploaded a progress shot with the dental monitoring app, and the case looks fantastic.
Wow. Great.
So it's the whole idea of, with a straight wire appliance, you trust the night tie. That's what everyone in the company, we tell our customers, you got to learn to trust the night tie to take you home, take you to the end result. So
That's awesome. The more stories like that you hear, the more people are going to adopt it for sure.
yeah, it's like I said, we keep learning from our users. It's been a lot of fun.
So how does, if they're trying these new brackets, how is it changing what the staff is doing? Is it benefiting the staff? What is the change in their lives besides now possibly doing bonding, of course?
Yeah, I mean, it gives them more responsibility, and we've seen that really energize staffs. One thing we've been doing, a lot of the doctors have asked us to do virtual onboardings with their staffs during this little break. And so it's a way to keep the staff engaged, keep them learning something new. But it's nice for them because a lot of the things, like if a bracket comes off, they can just take care of it. Maybe the doctor comes by to check it or give the patient a high five, whatever. But there's not like this line of assistants waiting for the doctor. Like I remember, like when I'm in practice, sometimes we get really busy. I'll have 3 assistants or so waiting for a check or something.
Mm-hmm.
In this case, with LightForce, it's there's not as much of that because there are fewer wire bends, fewer brackets debonding.
And that's just eating up time. There's people sitting in chairs in
Yeah.
the waiting room while you're waiting for the doctor. Yeah.
Right. Well, you think about your biggest expense is your staff.
Absolutely.
So, yeah. But also we've been very involved with the treatment coordinators. So we talk a lot with treatment coordinators. We have scripts because custom brackets haven't really been out there. There hasn't been a fully customized bracket before. And so for treatment coordinators, they're telling the story to patients for the first time.
That makes sense.
So like telling the story to mom or dad, whoever's in the office with the son or daughter, or themselves, saying, we know we can get your child's teeth to this position, and they can share the software and say confident, we know we're going to get there because we're making brackets that are only going to fit little Susie or Johnny's teeth to get them to that end result, versus using a one-size-fits-all bracket made from a mold. So And by the way, they're 3D printed. People seem to
Yeah,
get
that's kind of just
attached
cool.
to that too. Yeah, I know, exactly.
I'm sure the kids are excited about that, the young kids.
Yeah, it's funny, just my personal experience. So our brackets are a little bit more opaque. They're more white, which is odd for some orthodontists, but for the kids, it's like super exciting. So the girls come in, and the girls, they don't care about the customization. They just want the white brackets. They can make the colors pop. It's the same color as
Yeah.
their AirPods.
Okay.
And then the boys, they are more into the 3D printing side. So then you talk to them about, this is 3D printed. It's fully customized and sophisticated furnaces and things like that make this. So
that's cool.
Different stories, yeah.
Is the value to the customer, the customization value, really obvious to a customer when you explain it to them?
Yeah, it's very obvious. I mean, they, especially when you tell the story that you're unique. Your child's face is unique. Their teeth are different sizes. Their jaws are different sizes. Their lips rest on different positions. That has implications for how we want to finish your case. We want to show this much incisor, it's smiling. We want to show a constant smile arc. We want to correct this. We want extra help correcting this crossbite in the back or this class 2 relationship. All those things don't fall in the bucket of a one-size-fits-all approach.
Yeah, for sure.
The only reason we've been doing that for the last 70 years is because, like I said, due to limitations in manufacturing technology. And now, for the first time, we have the ability to fully customize fixed appliances, brackets. And so it's an easy story to sell, we've seen it be a conversion tool. So of our customers, being able to say we're one of the first practices that uses a fully customized approach, and we treat your child as a individual. Now, this is not to say that you're not treating people as individuals by using stock braces. That's just not true. I mean, we can bend wires, we can reposition them, and that's where the artistry lies. And we can do a good job doing that. But it's a question of efficiency. How do you get there in the most direct path?
Mm-hmm.
The other little anecdote we use quite a bit, or I've heard our users use, is I could take a direct flight from Boston to California, or I could take a round trip, having a layover in Canada first and then in Mexico, and then getting there. That's going to result in extra tooth movement, maybe some extra tooth pain, and a little extra few more appointments and longer duration. But we'll get there.
So that you've talked about a couple of benefits from the customer's point of view. So I'm hearing less pain in general. Is that something you can say?
I can say that theoretically.
Yeah.
So here's what I'm very conscious of. So my background, like I said, did the PhD, and it's very ingrained in my head. The only way, like, for example, you're going to fail your dissertation is if you say something confidently that you can't back up.
Gotcha.
So one thing I think we've seen in the orthodontic industry all over the place is we move teeth faster. We move teeth X number of months faster.
Yeah.
Blatantly not true for a lot of cases. So not for our case either. We don't move teeth faster. We just don't. The osteoblasts in class, the bone cells that move teeth, they don't care what brand of bracket is on the teeth.
Gotcha.
What they respond to is vectors of forces.
Yeah.
And so they will go where the force tells them to go. So my position is we don't move teeth faster. We may take them in a more efficient path.
So you get to the end result from A to B faster, but the teeth are not actually moving faster. Is that what you're saying?
Yes.
Okay.
Yes. And I want to qualify that with a might or yes, we will. But until so what I don't want to do is end up on one of these blogs. Like, I love Kevin O'Brien. He was our speaker at Harvard Commencement. Great guy. Admire him a lot as an academic. And I've learned a lot from his posts. You want to be very cautious about your claims until you can, provide some level of evidence, whether even if it's, not the highest on the pyramid of evidence, but like a retrospective study or something.
Yeah.
You want to show that you're treating cases faster. So I'm hesitant to say we treat cases faster. But what I can say is that we will guarantee that straight wire finish. So we've done that ex vivo in lab testing setting where, yes, you absolutely get a very accurate straight wire approach. What you put in is what you get out.
Yeah.
But to take that extra step to say that, yes, we move teeth faster, we're not going to do that.
I gotcha.
until we prove it.
Yeah. Oh, at least
Yes.
good to know you have integrity about it.
But we can say anecdotally with conviction we are saying that.
Gotcha.
Yes.
So how do you get the brackets in the right position? Can you talk about that? How does that work?
Yep. So we use an indirect bonding tray.
Yeah.
Which those have been around for 30 years. That's nothing new. What is new is the approach to it. So my background with indirect bonding is I watched my dad go through many cycles of it, and unsuccessfully so, because as of last year he was doing, or not last year, but several, up until LightForce, he wasn't using any indirect bonding in his office.
Wow.
He tried it with, you draw your crosshairs on a stone model and then bond the brackets with a sugar daddy on the back to make it stick, and then pick it up with silicone, all that. A lot of effort involved. And
Wow,
then you couldn't, sometimes the brackets would fall off because you still have a stock base. And then if the teeth were crowded or rotated, you couldn't fit the brackets on that fade point. You still have to direct bond later. So the many little issues that come up with indirect bonding, and a lot of orthodontists candidly have, PTSD from those experiences.
Gotcha.
So we saw that I just actually had a good conversation, good friend Dave Sarver this morning about that. Indirect bonding is a linchpin to any custom system. And so it was very important for us to take a new approach to that and look at how we can improve it. So indirect bonding today, even 3D printed indirect bonding trays, are death by 1,000 paper cuts of inaccuracy. It starts with how does the bracket fit in the indirect bonding tray?
Yeah.
And then it goes to how does that bracket get applied to the tooth? And then how much cement space is between the tooth and the bracket? So all those things can add up to the point where you'll get a bracket debond.
Okay.
And then you lose so much value from the indirect bonding experience. You put all this effort into the setup, and now the brackets aren't on there. So first, we started with we made the first bracket that is intended to be indirect bonded. So our bracket design from the beginning is around a bracket that is meant to stay in a tray.
Okay.
So what I mean by that is when you put whatever cement you put on the back of the bracket, or a bunch of different cements, the bracket's not going to come off on the end of the syringe.
Yeah.
We actually had a clinical trial at Harvard that we had to postpone because the 3D printed indirect bonding trays didn't fit the brackets snug enough. Like the brackets would wobble out if you pasted it. The bracket would come off on the end of the cement tube.
Yeah.
So we started that way, and we had a pretty quick and dirty test for the fit. We would say, all right, I should be able to take this indirect bonding tray, fully loaded with brackets, and throw it against the wall, and all the brackets should stay in it.
That seems reasonable.
Yeah, right? I mean, they should stay. So as Kelsey Fafar, our director of hardware engineering, that's our first test. I remember doing that very vividly. And so they resist high frequency, low torque force like that. Whereas there are so many algorithms that allow for them to be released the right way, rocking off from one path in the lingual, looking at all the 3D data, looking at what's the clearest path for them to be taken off. So they don't tear, and they come off easily with low torque, high torque, low frequency force, which is what would be involved in taking it off the tooth. And so there are other algorithms that are involved in placing the correct amount of labial force on the bracket to the tooth. So just by virtue of seating the tray, you're going to get the correct amount of labial force. That changes tooth to tooth based on many different factors.
I can imagine,
and this is some of the stuff we geek out about out in Cambridge here at HQ. Because there's so much math involved in this stuff that people just haven't thought to
and the
create.
end result is they stay on when they're supposed to stay on, and they come off when they're supposed to come off.
Exactly.
Yeah.
But it's funny. I point to all these issues in indirect bonding, and our engineers have, they have a direct line to many of our customers, and they would ask, what are the things you don't like about indirect bonding in the past? And our engineers see this as a challenge. I don't think that people have taken this deep of a dive in indirect bonding in the last 2 decades, as we're taking, and our engineers hear this feedback like, oh, we can come up with a solution for this. Let's, they work on an algorithm, they try to test it. There's the R&D cycles at LightForce are incredibly fast.
Oh, that's good.
And so we're very happy with the indirect bonding product we've put out, and we have to, because as I mentioned, that's the linchpin. You don't want to use it if they're not going to stay if they don't go where they're meant to, and if it's cumbersome in your workflow.
Yeah. So, can't have any obstacles to adoption, right?
Right. Exactly.
So what are some of the best clinical applications of LightForce you could tell us about?
Yeah. Well, there are no cases where it won't work on. So we work with impacted canines. We have algorithms to mirror image contralateral teeth, mixed dentition. And I would tell you the cases that, I'll start by saying the cases it's not great for. This is a tool to use in your private practice just like you would any other bracket. So if a patient comes in saying, I only want treatment if I can get a clear aligner, that's fine. Give them clear aligners. You're not going to, you don't want to jam that down the patient's throat. You give them their options. Say, I can do this with this tooth moving tool. I can do this with this tooth moving tool. These are the, considerations, but you give the patients their options, and then you advise and then react. But I would say the best cases, and some of my favorite cases, are coming out of the craniofacial department at Boston Children's Hospital here in Boston. So a lot of cleft lip and cleft palate cases that are super exciting for several reasons. One is a lot of these are canine or premolar substitution cases, even some lateral substitution cases where you're trying to disguise teeth to be teeth. They're not. And then so like for canine substitution, you want to reduce the canine eminence. Maybe you turn the 4 into a 3, try to lift the lingual cusp. So engaging torque and actually making that torque happen, super valuable in those cases.
Of course.
Super valuable in those cases, yeah.
Anytime you can help kids like that, that's great. Absolutely.
Yeah. The other component that is just indirect bonding is I think what some of the doctors there, my friend James McLean, he does a fantastic job over there. Some of them have mental considerations, and so they're not as compliant. And so getting some of those patients to open their mouths for an hour and a half is very challenging. Whereas with our system, you can go in there and etch prime and be in and out in 25 minutes in upper and lower bonding. So it's, and you can be accurate. You don't have to be fighting a tough child with their tongue, their cheek, and trying to bond molars.
So there's a significant amount of less chair time for the patient. Is that one of the benefits?
Yeah, I would say that, yes, definitely a benefit. And it starts day of bonding, having the cheek retractors in for less time. So you can easily get in and out, upper lower bonding with fight turbos for under 30 minutes versus some people's practice that's 90 minutes. And then obviously fewer unknown issues coming up later in practice. When we book like 15 minutes for a checkup, it stays 15 minutes. It doesn't turn into like a 45-minute. All right, we're going to rebond brackets or reattach brackets or do some.
Oh yeah, that just ruins your whole day. Everyone gets angry. They're all sitting and waiting, and
exactly. It streamlines your workflow. It helps you. Yes, it makes life much more efficient.
Yeah, I can imagine that's going to make a big difference on the bottom line for the doctor once they kind of get their groove and get it going. All right, so if someone's interested in getting started, they want to give it a try, learn more, what should they do?
If they want to learn more, they should reach out to info@lightforceortho.com. And we are being very methodical with our onboarding. So we're trying to limit it to 30 a month. And we take a very focused approach towards it. So we want to talk to your staff. We want to make sure that they're doing a great job with their bondings from day one before a real patient even shows up. So we send out a 3D printed model with practice trays where they can actually practice doing the indirect bonding on a 3D printed model.
Smart, yeah.
You want to put a little less cement on a fully custom bracket because it's an exact anatomical fit. So want to see them practice that once before a real patient comes in. Then we also do onboarding with the treatment coordinator so they can present it to the patient the best way. And then also we do a dive with the doctor, show them all the tips and tricks. Most doctors that are digitally savvy, that do a lot of clear aligners, understand how to read, move teeth on a computer screen, read occlusal contacts. It's super simple. It's very streamlined with the existing digital workflows that most doctors use today.
Yeah, so there's just not a huge learning curve. It kind of naturally works for them.
It's very intuitive. We've tried to match a lot of what doctors already know and love, and that's a big part of our culture is meeting orthodontists where they are today, reducing the headaches they have. And that even goes into the homework they have. No one wants to, have a lot of us, I even do this myself, have a lot of, I don't say Invisalign, but, any clear aligner homework to do on Saturdays or late at nights. With LightForce, it's a little bit different. You don't need to watch a video and ask yourself, is that tooth going to move? If so, or if not, do I need to put an attachment? If so, how big is it? Where does it go? We're using braces and wires, so it's going to track. So a lot less homework. I would say about 20% homework. So we put a lot into the user experience, the user interface to make it very streamlined.
Yeah, so it sounds like we identified a bunch of different areas to make sure that it won't be an obstacle for adoption. People will feel happy with it and won't be any issues.
And if there is, we want to hear about it. So we react very quickly.
Yeah. Well, it looks like we're good. Dr. Griffin, thanks
Super.
so much for all your time. It was really appreciate you having you on.
Yeah, great speaking with you, Rich, and hope to see you in person when it's legal and taking some sun in Charleston.
Yeah, absolutely. All right,
Awesome.
Well, take care.
You too. Bye-bye.